Inline and in. Okay. All right, welcome back. It's my great pleasure to welcome our final presenter today. I'd like to welcome Dr. Denise Hien. All right. Dr. Hien is the Vice Provost of Research in the Chancellor Provost Office, Director and Helen E. Cheney Endowed Chair in Alcohol Studies of the Center of Alcohol and Substance Use Studies, and Distinguished Professor at the Graduate School of Applied and Professional Psychology at Rutgers University, New Brunswick. Her body of work has contributed to the evidence base on the treatment of individuals with trauma-related psychiatric disorders, their comorbidity with addictions, through conducting single and multi-site clinical trials across the United States in community-based substance abuse treatment settings. She is board certified in clinical psychology and has served as a standing member on the National Institute of Drug Abuse, NIH, institutional review groups, and a health disparities advisory group to the NIDA director on Asian American Pacific Islander issues. Please welcome Dr. Hien.
Thank you so much, and I'm very happy to be here, and thank you so much for Dr. Deneke for inviting me, and Julie for doing all the logistics, and I wanted to also thank Dr. Smith, who has presented a wonderful sort of lead in. So our two presentations are of a piece, even though I didn't know what she was going to be presenting on, so I really appreciate that. As Erin said, I have spent the better part of my career doing clinical trials work on traumatic stress and addiction, mostly working with communities in New York City, Harlem, and the upper Manhattan urban populations. And so a lot of the work that I'm going to be presenting will be based on those experiences. And I'm going to be talking to you about the course of where I see our field going, and also the good news that we've learned about the kinds of treatments that we can offer for individuals with both traumatic stress related conditions as well as substance use. But before I get all started, I want to make a land acknowledgement to say that Rutgers University, where we do our scholarship and research, stands on land that is ancestral territory of the Lenape people. We pay respect to indigenous people throughout the Lenape diaspora, past, present, and future, and honor all those who have been historically and systemically disenfranchised. We also acknowledge that New York, New Jersey, and the United States as a nation was founded upon the exclusions and erasures of indigenous peoples. And I don't have any other disclosures other than the fact that my work has been supported pretty much continuously by the National Institutes of Health, National Institute on Drug Abuse, NIAAA, and other federal funds. So to bring us into thinking about the individuals that we work with, what it feels like. I know it ravages my life, but when I'm high, I don't have to feel it, the trauma in my body, in my soul. I can disappear. A few hours, a few days, a few weeks, a break from those relentless memories. Well, at least I know exactly how I will feel when I use substances, good, bad, or ugly. Otherwise, I'm all over the place. And these are just some of the voices of the individuals who we aim to provide care for, and who Dr. Smith, sort of laid out the landscape of the kinds of experiences that people who have addictions come to us with. And so I've spent most of my career as a clinical psychologist working in substance use treatment settings, trying to address the issues of trauma as they appear for our clients. So I'm going to go through, and my slides will be available for anyone who because I'll kind of go through the slides relatively quickly, so we also have time for conversation. But I want to sort of present the landscape of comorbidity and its consequences, the science of what we know about integrating trauma, PTSD, and substance use care, and then how to kind of think about clinically applying an integrated treatment framework that enables us to look at both the emotional and psychological and psychiatric issues that go alongside substance use and addiction. So in terms of comorbidity and consequences, first, I'm giving you a little bit of the landscape of addiction. I talk to lots of different audiences. This audience is a very, you guys know all about substance use. And you know about the opioid epidemic and how many lives we have lost. But I like to make the point also that while the opioid epidemic is still an epidemic, it's not endemic yet. And then we have made tremendous gains thanks to medications for opioid use disorders and the kinds of interventions that we've employed. People are still dying at enormously high rates. And just wanting to make the point that there are real disparities. So where the country made a kind of national recognition of the epidemic of opioid use through many deaths of younger white populations. So it came to the attention. I mean, our country has been faced with addiction issues, mass incarceration in our racial and ethnic Black and brown communities for decades. And those deaths are now, in terms of even in opioid deaths, the curve for I just show this slide, this green curve, if you can see the steep curve. So in the white population, it's sort of starting to taper and maybe will start going down. But what we see is that for those who are African American, the rates of fentanyl related and stimulant related combination opioid deaths is still on the rise. So it's just important for us to know. So when we think about substance use, not only mortality, but also individuals living with substance use disorders, we know that DSM-5 has moved to thinking in a more continuous model. And I'm not going to spend a lot of time going into the different diagnostic categories because I think I'm talking to an audience who knows all about that. But I like to make the point that there's a real spectrum of issues that many of, in our country are facing when we think about substance use, and that go from at risk to severe. But what we see here is in the past year, in terms of that kind of a spectrum, we have about 40 million people who are dealing with some type of substance use disorder. Alcohol and other illicit drug use are the highest rates, and you can see heroin use disorder is actually one of the lower, rates of among those with substance use. So alcohol, the point made earlier about the importance of thinking about alcohol, and now marijuana use disorder is also on the rise. This is a little bit of an older slide that shows a different number of Americans facing over the age of 12 with substance use disorders. But the point of this slide is really that only a small fraction actually get any kind of care for their substance use in terms of treatment. And there's a number of reasons why many are not ready to stop using. And so they are not in a place of choosing to come for help. But there are many other barriers that make it hard for people to get the care that they need, such as insurance, availability of providers, worried about stigma is a huge impact, and job in terms of job, employment, and also family and community. So we have a big challenge that we continue still to face, and places like Karen, who provide high level of care, are really not as available to everyone as what we really need. We also know that people who live with mental illness use drugs and alcohol, and an estimated 50% of adults over the age of 18 have serious mental illness, and another 40% have acute mental illness. So these are undeniable facts that we know from our recent epidemiological studies. And I show you this slide because it's really still, unfortunately, the elephant in the room, is that co-occurring misuse of substances is the norm rather than the exception in psychiatric populations. And on the flip side, in our individuals with substance use disorders, we also know that we have extremely high rates of mental health conditions. And just to add another layer on what we learned as we went through the pandemic is, and we've written about this, is that a syndemic is when multiple epidemics collide. And so we had the opioid epidemic, we had the racial reckoning, which has also been thought of as a racial epidemic, racism epidemic, and we had the pandemic, and which really laid bare our awareness of how the inequalities that there were in terms of people's ability to access healthcare and the outcomes that people experience. So we heard a lot about that also in Dr. Smith's talk, and that really at the center of that is traumatic stress and those ACEs that people are exposed to, and then also ongoing traumatic events through the course of life, whether it's exposure to other traumas through a disaster, natural disaster, look at what's happening to us in terms of our climate change impacts, as well as interpersonal violence and other kinds of traumatic events. So, you know, we have our work cut out for us. And post-traumatic stress disorder is one of the consequences that we see in adulthood. We can also diagnose it in childhood, but really I'm focusing on adulthood in this talk. And it affects 8 million people in the United States. There are higher rates of PTSD among women than among men, but 5 to 6% of prevalence in men and 10 to 14% in women. It exacts a very high toll economically on our society. And many of the causes are obviously stressful life experiences, trauma, mental illness, and racism could be another one listed under there. And then we have risk factors for developing PTSD. I think this gets to one of the questions that was raised in the Q&A regarding, you know, the fact that people who have childhood sexual abuse are, of course, may be more predisposed, more likely to have developed post-traumatic stress. And it could be not from childhood, but that something then happens through the course of life that they have a susceptibility to and then end up developing PTSD. And of course, a lack of a sound, those PACEs, that sound support system, can all lead to, you know, PTSD. And then, you know, we also have to think about the fact that trauma not only leads to PTSD, which is something that we, you know, we focus on in our work, but also leads to other, you know, other mental illness, mood disorders, anxiety disorders, other conditions, and substance use. And so the symptoms of PTSD include negative, well, really the hallmark symptom is what you think about intrusion, which are those memories that are haunting you of the traumatic experience. There's also negative alterations in your mood, hyperarousal, so that stress system is active and activated and at a toxic level at all times. And then there's functional impairment, so a person may have difficulty in love or in work as a consequence of some of their symptoms. And then there's avoidance, which is another feature, avoidance and numbing. It's part of the diagnosis of PTSD. And how do you avoid? Well, using substances is a way that helps people avoid. Using substances can also be a way of managing the hyperarousal and reactivity by helping the person tamp down the feeling that they're, you know, about to explode. And so there are lots of pathways for connections between having these kinds of symptoms that coalesce into a disorder and that also help lead the person to use substances. And I'll talk about pathways in a moment, but just to show you some of the numbers, no matter which way you look at it, the epidemiology, we have national epidemiological studies like the epidemiological catchment area study, which looks at large populations and looks at numbers of co-occurring conditions. We have clinical samples when we go to psychiatric settings and ask people about what kinds of, and do diagnostic interviews with them. We have settings where we go to substance use programs and talk to people about their mental health conditions. And it doesn't matter, trauma is ubiquitous. It's more the norm than the exception. And so people are 6 times more likely to develop an alcohol use disorder if they've been exposed to a trauma, and 2.5 times more likely to develop a substance use disorder. And then in terms of this graphic kind of shows you that for men and women, how many disorders, if we think about like from a psychiatric perspective, it's more common for people to have, not only if they have a substance use disorder, to also have PTSD and maybe also have either a mood or anxiety disorder. So it's more common than not. So, you know, to the point of screening, I know the point was made about whether you should or shouldn't screen for ACEs. I think it depends on what kind of setting you're in, and absolutely, it's, you know, we don't want to screen and not be able to offer care or referral. So that's, but certainly for those of us who work in an addiction context or who work in a mental health context where we do have the ability to talk to our patients and figure out what's going on, we really need to be talking to them about multiple conditions. And so here we have, you know, what's the relationship between the two, and really there used to be this question when I first got into this work about 30 years ago, we saw that the two co-occur, but really it seemed to be a correlational question. It wasn't like, did one cause the other? Now, all of the science basically has shown us that there is a relationship, and the relationship is such that we have the self-medication model, which is a typical idea that a person has been exposed to ACEs or been exposed to a traumatic experience in life, they are more likely then to develop a substance use disorder, and there's a causal relationship. Now, you can also have a high-risk lifestyle. So as a substance user, you could have a high-risk lifestyle that leads you to being traumatized. For example, if you're using substances and you're intoxicated, and then you might be more likely to be experience some kind of an assault, and then you may develop PTSD later. But the science really shows us that it's the trauma and the early trauma that comes first, typically, and then the substance use comes later. And so we have a multidimensional model where we, you know, nothing is as simple as only one experience just leads you to, you know, the destiny of developing a substance use problem. But obviously we have the neurobiological effects that we heard about earlier and that you heard about earlier today. But there's certainly neurobiological mechanisms that predispose people who've been experienced trauma, who have hyperactive, you know, the HPA axis, the stress system is activated, and that, you know, predisposes them to use substances. There are also personality characteristics that and early life stress that we heard about, as well as genetic factors that show that individuals have polymorphisms that can lead to the shared occurrence of both conditions. But so in terms of covering PTSD and substance use in terms of impact, we know that if you have a diagnosis of PTSD and substance use, you also likely have more other psychiatric issues that are more severe. You're less likely to get the help that you need. There are higher dropout rates for individuals who have multiple comorbidities, and you are at more increased risk of relapse. So, you know, we know that more bad things that happen to you and that you are carrying in terms of the emotional tolls lead to worse outcomes. And then I will mention also the concept of complex trauma, which I think Dr. Smith showed you the book, The Body Keeps the Score. And this is the idea that in addition to early life adversity, Individuals with substance use who have trauma also may have difficulties in trust that lead to difficulties in interpersonal relating, affect regulation or emotional regulation problems, and PTSD and dissociation. So we're dealing with a lot of challenges, and this may make everyone sitting here this afternoon on a Friday afternoon, and I realize I'm the last thing standing between you and your weekend, so sorry, Erin, you put me here. But we have good news, and that is that we do have, the last 25 years of clinical trials and work that has been done in this space, which we heard about Dr. Najovitz and the Seeking Safety model, which I will talk about. But we know that there's a science, and we have some answers. So you'll be walking away with some answers today about what we can do to help individuals who have these comorbidities. And there are a number of things we can do. And just this is in contrast. We heard a lot about trauma-informed care, which is sort of a base layer of really thinking about how we talk to our clients, how we listen to them, what kind of environment we provide for them in terms of coming into care. But what I'm talking about is also evidence-based treatment models that we can employ to help. And so what we've known is that the phase-based treatment approaches are key. And so we have the idea that first, when people come to us and they are in a crisis, they're actively using substances, they also have high psychiatric symptoms. Our job is to try to help stabilize them and to do skills training. And so I'll tell you what that means. But we really focus on helping to regulate affect, helping with distress tolerance, and focusing on getting person out of an acute situation. The next idea that we think in terms of that, then what, is to process. And processing means doing trauma-focused work. And we have a number of evidence-based treatment models. Some are exposure-based that are bottom-up approaches where you try to bring the person back to the traumatic memory, have them re-experience those memories in a safe context, and help them to become less and less dysregulated by those memories through a specific way of processing called prolonged exposure, or cognitive processing therapy, where you're talking to the person about the cognitions that arise on when they are in a traumatic situation, and helping them understand that it wasn't their fault that the trauma happened, and a lot of other tools that we can bring for our clients. And then somatosensory processing models, like you may have heard of EMDR, or other approaches that focus on a body-centered approach to allowing the body to tell the person, how they're feeling, and a therapeutic process that goes into that. And so it used to be thought that you couldn't do PTSD treatment until the person was abstinent, that we can't do, and so a lot of people would come to substance abuse treatment settings and would be told, listen, we're not going to go into your trauma, you've got to get into recovery first. But remember, what we see about the relationship, if we don't address the underlying condition, it's very hard for a person to be successful in getting abstinent. And so we certainly, in our work, in the research that we do, encourage a harm reduction approach as opposed to requiring abstinence. And we have also learned, and I'm going to tell you the punchline before I tell you the whole story, that we can do trauma-focused models with our clients. And not only can we do them, but we can also do them successfully. And I'm going to show you the evidence for that. But certainly the idea that siloed care is harmful is something that I do want to get across. So you cannot have a whole person come to you and say, listen, I'm only going to take care of this one arm, when you are, it's a whole person problem. And so this is what we encourage people to be thinking about. And so now we have over 50 clinical trials, believe it or not, that have been conducted in the PTSD and SUD space. And one of the facts that we know is that you can treat PTSD, and it's safe and effective to do it with people who have substance use disorders, even if they're not in full recovery. So meaning even if they're not abstinent. And so we heard about Seeking Safety, which is a skill-based model. So that's an early stage model of intervention. It focuses on psychoeducation. So one of the manualized sessions talks to clients about their about their ACEs and about the symptoms of PTSD, and basically provides a framework for the person to understand that their disparate symptoms are actually a consequence of the trauma that they've experienced, and not that they're crazy. The Seeking Safety model was the first one that was tested in early clinical trials. We did a number of them in New York City. I did a multi-site clinical trial in 7 different states, and we were able to show that you could train providers at drug and alcohol counselor level and beyond to do the Seeking Safety model. And in fact, Lisa Najovitz also has a peer, some research that is, and an app, so that peer specialists can deliver this intervention, which is really focused on coping and safety and helping the person to talk about trauma, but not to process their trauma. So this type of model is that phase 1 kind of model that does not do the processing. What we have found in the last 10 years is that actually our clients are not as fragile as we think they are, and that you can do the trauma processing approaches that I was telling you about, prolonged exposure, other kinds of trauma-focused approaches we have shown to be efficacious. And in fact, there was one trial that was published in JAMA Psychiatry in 2019 that compared the Seeking Safety model to an exposure-based model. So again, the skills-based stabilizing versus processing models, and showed that the Seeking Safety was the processing model was superior to the Seeking Safety model. So I'll speak to what the implications of that are. But the other thing, so the question is, should we wait? And you're going to know what my answer is. And so here's my answer. No, we should not wait. We should not be waiting. Our clients can tolerate the kind of trauma work that they need to help them get into recovery. And so we know that the combined treatments are tolerable, safe, and effective. I couldn't say this even 10 years ago. Now I can say it with confidence. And that more trauma, when we look at studies where we look at, what changes, does the substance use change? Do the PTSD symptoms change? If you can get the PTSD symptoms to go down, you see impacts on substance use outcomes. So until you can really help a person reduce their PTSD, you may not see lasting impacts on their ability to get into recovery. And the opposite is less true. So we're not seeing that if you just get somebody into recovery, their PTSD will go away. No. And does that make sense? I mean, I think it makes sense to clinicians who work with this area. And then the other thing that our studies have shown, this was one of the studies I did in New York City, was comparing a trauma processing model to relapse prevention. So the blue is the relapse prevention, and the yellow red curves are the trauma processing model. And the gray box basically is showing you as the person's going through different weeks of treatment. So this was 12 sessions, and then a post-treatment, a 1-month follow-up, 2-month follow-up, 3-month follow-up. The gray box is people that got clinically significant change in their PTSD severity. And so what we see is that even though everybody is kind of going down during the treatment process, it's only the people that got the trauma-focused therapy that make it into the gray box, so have made gains. And that includes those who were the heaviest users. So this light blue line are people that got relapse prevention that were using at least 4 times a week. So during the course of treatment, they were heavier users, 4 times or more per week. And this yellow line is showing you the people that got the cope treatment, and that were also the heaviest users. So even the heaviest users, when they got the trauma-focused treatment, they had clinically significant change, whereas those who didn't, who got the sort of just let's focus on reducing your substance use, didn't actually get those benefits. So that's just another example of data that is pointing us to the fact that our patients are not as fragile as we think. And these were patients who weren't getting any this, they were off the street in New York City, didn't have many other services or supports, and came to us for their care. So that's what that, oops, I didn't give you that. And so now I want to shift a little bit to talk about pharmacotherapy targets, because we have a number of different agents that have been developed over the course of years to treat substance use. So we have treatments that focus on alcohol or substance alone. We have agents that target PTSD like Paxil or sertraline or Zoloft are FDA approved for PTSD alone. We have agents that target both. So sertraline is one of the agents that has been approved to target both. We have agents that target craving like disulfiram. These are medications that you all know about, or rather targeting craving, no, aversive agents like disulfiram, and agents for withdrawal. And we have a number of systematic reviews that have been done that have been looking at which medications are best for PTSD and SUD. And basically, the jury is still out, although I do have other data to show you in a moment. But what we do see is that medications, these medications have been shown to be effective. None have shown, there's no evidence that suggests that you shouldn't use them as you would use them for a single disorder, but we still don't know what are the best practices in terms of the combined PTSD and SUD. And part of the reason is because of the challenges of doing this kind of research. The sample sizes are small. We see impacts mostly in PTSD, not necessarily directly on substance use. There are high rates of, our clients are hard to treat. They have lots of problems. And so having them stay in a clinical trial is also very challenging. There are also kinds of a lot of, for medication trials, they're even more difficult to maintain and keep patients in trials. And so it's been very difficult to get some of the answers that providers and programs and agencies that serve our clients really need to have. And so one of the things that we did, and this is the last study I'm going to talk about, is what we called Project Harmony. And it's a data science project that is our effort to try to answer some of these comparative effectiveness questions. And what we did was we pooled all of the individual patient data from every clinical trial that we could find in the world. And we had 42 trials that we were able to pool data with us for 4,500 participants. So this kind of scope of trial, allows us to look at some of the questions and have more power to answer the questions. So I'm just going to give you a tiny, sort of spotlight on some of our answers. And this was a team of a lot of people who do treatment trials with individuals with PTSD and substance use from all over the country. So my partner, Antonio Morgan Lopez, my work partner, is at Research Triangle International in North Carolina. We have individuals from Medical University of South Carolina, University of UCSD, San Diego, Yale University, North South Wales in Australia, University of Washington, Stanford University, all of these people pooled together. They shared their data with us, as well as a number of other folks. And so we have publications that I can direct you to if you want to know more details. But we created an international consortium of addiction, stress, and trauma researchers from all over the world. We categorized all the different treatments that had been offered and tested for people agnostic to what they were. So we included any trial where they had good data on who the participants were and measures of both PTSD and substance use outcome. And we also were able to categorize behavioral treatments into different categories. So we had 8 different classifications of treatment types, and then we compared them to a number of different controls. And so we did a systematic review that's about to be published in Psychological Bulletin, and a network meta-analysis to kind of characterize all the trials. And we were able to pull out trials that were behavioral in nature and look at the network of different types of treatments that were offered compared to a treatment as usual or a psychotherapy control treatment. And then we also had trials that were medication alone, and we're able to pull those medication trials out and do comparisons that had not been able to be done in previous systematic reviews. And essentially what we found was that for the psychotherapy trials, the trauma-focused models were superior to all other models in reducing PTSD. And for the medication trial, we found that the combination of either trauma-focused and alcohol targeting medications were significantly better at impacting alcohol outcomes than any other of the treatment types. I'll let that sit with you for a minute. But then we also did another sort of fancy analysis of using all of the data from the 4,500 participants. And, I can go into, what we, all the statistics that we did. But basically, the way I like to talk about this, so you hear, for those of you who are stats eggheads, you can read the slide. But what I like to say is what this trial did was basically on your iPhone, if you have an iPhone or Android, when you take a picture and that picture there's a little wand that you can edit the picture, and you just click on the wand and wow, you see the picture is better. It's like brighter, it's clearer, it corrects for all of the missing pieces. And that's what this analysis did for us. So it basically brought clarity to this question of which treatments are best, across all the different types of models that we can do. And so I'll just show you again and this was very similar to the systematic review and network meta-analysis that I just showed you, which is basically that if you see the green across here, we have PTSD outcomes at end of treatment in 12 months, alcohol outcomes at end of treatment in 12 months, and drug outcomes. What we see is that the combination therapy of medication and trauma-focused treatments has very large effect sizes for both reducing PTSD and also reducing alcohol. Whether it was delivered in an integrated way or whether it was delivered as just something like prolonged exposure for people who were in substance use treatment, we see similar findings. And so what we don't see here, and then there are other, alcohol meds by themselves were pretty good. And so was placebo in some cases, placebo medication. What we don't see is a lot of direct impact on drug use. And that's because I think what the next set of analyses that we're doing are looking at to what extent do the treatments help drive down the PTSD and And then will we see that once we've driven down the PTSD, we're going to see downstream impacts on drug use, and that's what we're expecting to see. But in the meantime, these analyses really give us like clarity on the fact that there are certain treatments that seem, so we like to say, there are no wrong doors. So all the treatments do something good, but some doors are better than others. So if you had a choice, if you have a client that you want to do, which treatment would you recommend? I'm going to recommend, if I feel it's appropriate, that my client start thinking about doing a trauma-focused treatment, and maybe we go for a psychiatric consult and have them make sure that they're also getting some medication that helps them with their substance use. So as I'm nearing towards closing, I want to talk a little bit about just the clinician provider perspective. What does success look like? These are the kinds of questions. What is it success if I'm still using? What kind of therapy is right for me? If you're a provider, what do I do if my patient seems to be getting worse? And are there different outcomes if by gender or by identity or by cultural identity or other factors? So these are the kinds of questions that providers have, because, I'm talking to you about a lot of the research findings, but we don't care about the research findings if you guys can't make use of them, if they don't get disseminated into the community. So for practitioners, I say, we want to adopt an integrative framework. We want to do comprehensive assessment. That's just good clinical care. We want to have a harm reduction model. So we want to motivate those people who maybe don't know if they want treatment to get into treatment, and also those people who might be afraid to do trauma work, to give them encouragement that, yes, they can. And then there are a number of treatment models that we can use that are out there that are not specific to trauma, but that many of you will know about, like DBT. And then we heard about TREM, the trauma model, but then there are a number of different kinds of treatments that we can employ and be thinking about as we open our portfolio. And then I think there are lots of interventions that can be taught to peer specialists, drug and alcohol counselors, and as well as individuals who have other kinds of training and background. But we want to emphasize multiple domain assessment, coordinated care, really thinking about bringing psychiatry in to help promote stability and prepare our clients for work. And so in conclusion, PTSD and SUD are highly comorbid and undertreated, if I haven't made that clear enough. Integrated care is safe and efficacious. And optimal care should be individualized and involves a client-centered harm reduction paradigm, comprehensive assessment, and evidence-based combined treatments. And with that, I want to express appreciation to the many thousands of clients that have participated in our clinical trials, as well as all of my collaborators at my various institutions. But I want to end with a poem that is from one of the clients in one of our treatment programs in New York City, that I think is an amazing story. She represents somebody who had probably the most severe early child trauma, or one of the cases where severe trauma, severe addiction with multiple heavy substances, and was in our treatment program. And this was her poem: multi-trauma survivor, heals to find wedded bliss, healing universe applauds, you are next. I'm a new house. I've come out of thick, tough hide, swearing by the rock I rubbed against, to be tender again, able to receive and give love from my most vulnerable, healed self, appreciating freshly discovered beauty from its fearless depths of honesty, feeling peace out of the gratitude of being accepted as is by the universe, myself, and the reflection in the eyes that behold me. I believed it for me, believe it for you. Thank you. So I think time for questions.
I think we have time for questions, and what a beautiful way to end it with that poem. I think that was a beautiful way to end the day. So thank you. Do we have questions from the audience?
I know using MDR, but do you also help use EFT? Are you familiar with EFT? Emotional freedom technique.
Say that again.
Emotional freedom technique.
Can you say a little bit about what that is?
Emotional freedom technique is you're tapping on the meridians of the body and you're saying what you're thinking and what you're feeling, because your feelings are right or wrong, but expressing it. But when you tap on the meridians of the body, it helps the body relax.
Yeah, so thank you for sharing that model. And that, though that one hasn't been tested as far as I'm aware of in a clinical trial, that falls into the category of the somatosensory type of trauma processing therapies. And those are a category of therapies that are found to be effective. So, not every therapy has been, gone through the years of testing, but
I do know that they use this for men coming out of war for PTSD.
Yeah, it makes a lot of sense. Thanks for the question. We have one in the.
Thank you for your presentation. So I have a question about treatment planning. And the question is this. In my career, I've seen wonderfully beautiful treatment plans that the client will never follow because it wasn't the client's treatment plan. And I guess my question is, when a client comes in the door, we assess and identify a myriad of issues. Can you speak to the process of empowerment and what issues the client wants to work on when, and how does that happen so that we're not replicating disempowerment and causing harm by working on issues that we've identified, but it should be the client's choosing of what issues to work on when.
Yeah, great question. So the question is about, empowering the client, and how do you develop a treatment plan with a client that will not feel like you've taken away the control from the individual. And I think that, we heard earlier also about the concept of trauma-informed care and the idea of collaboration. And then here, when I'm presenting our integrative therapeutic framework, I think any good clinical clinical work should be a collaboration. And so, and particularly with individuals who have been traumatized, where there are lots of issues around speaking, your feeling like your voice is going to be heard and not being squelched. It's important to engage the client in kind of a decision-making process. And I completely advocate that. I also think that, in our work, it is our job to do that. This is why I emphasize comprehensive assessment, because, when we go to a medical doctor for a medical condition, we don't want the doctor to just collaborate with us. We want the doctor to tell us, okay, here are the things, here are the steps that we need to take to get you better. And so we do need to, and why I'm saying this is because I think there's been a tremendous reluctance to go into trauma because people don't want to do harm. And I understand that. And that, to the earlier point that, you don't want to offer something if you don't have the treatment to offer. So, taking all that into consideration, I think that, and so for people who have trauma, they may want to avoid, or they have avoided with talking about what's happened to them, which is why they have developed other strategies for managing that avoidance. And so we need to, as practitioners, have a sense of confidence that, yes, in fact, we can help you talk about it in a particular way, and we're going to help you. And these the evidence shows that if we do that, and if you engage with me on this journey, and it doesn't have to take years. We're talking about these interventions, all of these clinical trials are between 12 and 20 sessions. So maybe about 3 months maximum. But in some cases, we're trying to do some of these trauma processing models, in even less time. And they're showing themselves to be quite effective. So I think it's both and, in answer to your question, like many, it depends. I see that there's also a question in the chat. Should I read it?
Yeah, if you can read.
I support treating trauma while working in a harm reduction model, but what if the use escalates while doing trauma work? How would you deal with that? So that is definitely a great concern that we have. And I'm not saying it would never happen, because sometimes things have to get worse before they get better. Our experience has been in lots of these clinical trials that, we have all kinds of protocols in place if someone's use escalates to a very, scary level. But basically there have been very few trials. So in that systematic review that I talked about, we looked at adverse events in the context of delivering these kind of interventions, and we're not seeing high rates of adverse events. So we're not typically seeing people start using more while you're delivering substance use treatment. It could be using more, but not necessarily to a level where you would think they would need hospitalization. But obviously, if you have to do what you think is best for your client as the treatment evolves, but you have things in place for when you're working with someone with substance use and they start getting worse. So I think sometimes we have to look within, and our fear, we have to address our own fear. And I think the science can help us with that, because the science is showing us that actually not only could we do this kind of intervention, but we should, because a lot of people benefit from it. I've worked with clients myself, and their lives have been transformed, and I don't say that lightly, through doing this work, where they've been haunted for their entire adult lives. And then they do a piece of trauma-focused work for a period of a couple of months, and then, that lifts. Other questions?
Yep.
This was the same
Oh.
question. Yeah.
But that is the same.
Yeah.
Just I guess a quick question, kind of piggybacking on that. Sorry, I know I have to be up here to speak into the mic. Sorry. I think that a lot of times the clinicians' fears sometimes get in the way of, like, that fear of, will their substance use get worse if I treat the trauma? But like your slides show, they're so intertwined. I'm so glad that PE is showing such promise.
Mhm.
But PE is a very, I think clinicians, that's a scary intervention for clinicians, because it's very raw for a client. So can you speak to how, trying to formulate this as I talk, how the use of PE helps with the symptomology to reduce the substance use, if that
Sure.
makes sense?
Sure. So just to speak a little bit about prolonged exposure and what, because it's sort of like a horrible name. Like, I didn't come up with that. But essentially what it is in a structured way, you work with the client, you tell them, here's a treatment model. What you're going to do is we're going to help you identify, the worst trauma, or the trauma that's haunting you the most. So you do a process of diagnostic work to identify if somebody has multiple traumas, like which one they want to process first. But so they identify, you're saying, we're going to identify this together. And then what you're going to do is you're going to tell me about it, and you're going to talk to me. You're going to try to remember all the details you can. I am going to just sit quietly and listen to you, and you're gonna tell me, and we're gonna record it. So I'm not gonna tell you all the instructions of a PE session, but just so you get a flavor of it. So the patient is talking to you about their trauma, you're recording it, and through the course of them talking to you, you're asking them about their subjective units of distress. So you teach them the SUD thermometer, which is like 1 to 10, you know, how severely distressed are you? And you keep checking in with them as they're talking periodically. What is your SUDS right now? They could say 80, you know, and then you'll say again, what is your SUDS right now? As they get into the heart of what happened to them. And they're supposed to talk in the present tense, and they tell you everything that they can. And then you do it over and over. And you also tape it. So they have homework. They have to listen to it when they go home, and they have to rate their own SUDS on a piece, you know, so it's a structured model. But if you think about it, it is when a client comes and tells you about their trauma, it's, you know, sometimes that can be very flooding. But what happens in this kind of a structure is the client knows there's a beginning, a middle, and an end. And you're also telling them why, as you're doing this, your SUDS will start to go down. And that's what happens. So even over the course of 2 weeks, the SUDS might stay high, but they see them starting to come down. And then there are other aspects of the treatment, but it's not as complicated as you think it would be. And now there are ways that you can get trained. Even the National Center for PTSD, which is part of the Department of Defense, the VA, has free PTSD coach. So you can go to their website. There's all kinds of resources for people to get trained. They offer webinars. That's just one example. And, you know, Karen Foundation could offer a training, you know, for people to get those skills. But, you know, so that's just one example. So yes, people have to get some professional development. But what we've found is that when we've done that, or in places that we've done our clinical trials, our therapists become the ambassadors for the treatment models, and then they become the trainers. So it's like a train the trainer model. So, you know, there's a lot of opportunity for getting more training, and I think people are very hungry for it. Yeah, so I don't know if
That answered it. Thank you.
now I'm putting it on you. You have to give us a training on.
Okay, all right.
Yeah.
Julie, did you hear that?
I do. Sounds like it's me.
Okay.
Should we,
Where did the PowerPoint go?
the PowerPoint? Oh, somebody wants the PowerPoint?
No, I just want to open it so we can wrap up.
Oh, sorry.
Oh, no, you're good.
Okay. Can
There's
we,
chat messages?
one
too.
more,
Oh, there's another one.
we have one last question coming
Yeah, we
in.
can probably do one more.
Okay.
So there's,
What might it look like to apply models in group therapy settings? Great question. And actually, there are a number of different variations on the theme that are being done in group settings. So there's a written exposure therapy called, terrible acronym, WET. But it is being done in PCORI, which is patient-centered outcomes research, very large trial in the VA and also with community-based treatment programs. And so that's a written model. So you can do it in group because people can work on their own personal trauma narrative in a written format. And then cognitive processing therapy, which is what I was talking about, also has been done in group. So there are models that can be done in group. Anyway,
Okay,
thank you.
No, thank you very much. If we can give a round of applause. Okay. I just want to thank everybody again for coming out today. And again, I want to thank all of our wonderful presenters. I love that we ended the day on a poem. That was an awesome way to end it. And again, a special thank you to our audience that have been here both in person and virtually for your participation today. We couldn't have done this without you. And again, please check your CE Go dashboard for your evaluations. They will be available, the CEs are available immediately, which is kind of cool. It's usually you have to wait a couple weeks for things. Again, in about 28 days, all the slides will be available, as will the recordings. For any questions regarding your CEs or your evaluation, please reach out to support@cego.com. Again, thank you so much. Thank you to our presenters. It's been a lovely day. Whoever would like to join me, I will go over to the Research Center if anybody would like to see that for an opportunity. Beyond that, I will say have a great afternoon, a great weekend, and enjoy. Thank you for coming out.